Hello and welcome everyone. Today we'll be discussing about vasoplegia. Now what is vasoplegia? It is a vasodilatory shock. It is a severe condition where the blood vessels lose their ability to constrict, leading to a persistent low blood pressure, which is shown by the low systemic vascular resistance despite the patient having a normal or a high cardiac output. The common causes being cardiac failure, sepsis, anaphylaxis, hemorrhage, and major surgeries. Most commonly seen after septic shock and as a complication of cardiac surgery. The clinical impact is that vasoplegia leads to worse outcomes like increased death rates, higher chances of renal failure, longer ICU and hospital stays. It has become resistant to catecholamines, then the mortality rate reaches as high as 25%. It is an independent risk factor for death regardless of what caused it. Often leads to multi-organ failure, bleeding and respiratory complications. Pathophysiology. The key mechanisms and mediators of this are nitric oxide, which is central to the vasoplegia, and it is produced in large amounts during inflammation and surgery, causes blood vessels to relax, reducing their ability to respond to the vasoconstrictors. So if you look at it in a stepwise manner, the nitric oxide activates the guanylyl cyclase, which increases the cyclic GMP, which goes on to reduce the calcium influx, which thereby relaxes the smooth muscles in the blood vessels. So the nitric oxide also increases the cytokines like bradykinin and thrombin and bacterial toxins. So these factors can also result in an increase in nitric oxide. So this overproduction leads to profound and a persistent vasodilatation even in the presence of very high doses of vasopressors. So the key mechanisms and mediators are adenosine. Adenosine is released during stress, especially by the nerve fibers and in low oxygen states. It lowers the blood pressure by dilating the blood vessels, affecting the heart reflexes. It doesn't directly cause any cardiac damage or muscle injury, but worsens the low blood pressure. Next, we have the prostanoids, that is the prostaglandins. They are released during the inflammation. They promote vasodilatation and contribute to the lower vascular resistance. They increase the inflammatory mediators, further worsening the vasodilatation. Next, we have the endothelin 1, which is normally a strong vasoconstrictor, can paradoxically worsen the inflammation by triggering more inflammatory cytokines in cases of severe stress. The balances between the constriction and dilatation can be lost if the patient is vasoplegic. Next, we have the RAS system, that is the renin-angiotensin-aldosterone system. It regulates the blood pressure and the fluid status. Normally, angiotensin 2 will increase your blood pressure by constricting the blood vessels. However, in vasoplegia, the system becomes less responsive, possibly due to the receptor downregulation and overwhelming effect of the vasodilator like the nitric oxide. Next, what we have is hydrogen sulfide. It is produced in the body during the inflammation. It opens the potassium channels, causing hyperpolarization and further relaxation of the blood vessels. It works alongside the nitric oxide to worsen the vasodilatation. Inflammatory cell involvement, you have platelets, neutrophils, macrophages activated during the bypass. That is in the cardiac surgery cases. The neutrophils release the enzymes and reactive oxygen species that damage the blood vessels. Platelets stick to each other and the vessel wall, adding to the dysfunction. Macrophages release cytokines and they activate more immune cells, causing inflammation and vessel relaxation. So how do we manage these cases? So the general approach is early recognition and prompt management of vasoplegia. Start with intravenous fluids to optimize the blood volume and start the heart before using vasopressor. In terms of vasopressor, the choices would be norepinephrine, which is the first choice. It increases the blood pressure effectively with fewer side effects on the heart. Epinephrine, dopamine and phenylephrine can be used as an alternative, but obviously norepinephrine or NORAD is the preferred thing. High doses may be needed but can cause complications like arrhythmias and tissue ischemia. Some patients may not respond, so they can be termed as vasopressor resistant vasoplegia. The second line, you have vasopressin, which is added when the response to the catecholamines is inadequate. It acts by the V1 receptor and restores the vascular tone, and it counteracts the nitric oxide. Methylene blue, it blocks the nitric oxide pathway, causes given a bolus or infusion, useful when nitric oxide overproduction is the main issue. You have angiotensin 2 for refractory shock, increases blood pressure by constricting the blood vessels and mobilizing the venous blood. Next, you have the hydroxycobalamin, that is vitamin B12 derivative, which scavenges the nitric oxide and hydrogen sulfide, and it is usually used as a last resort. Vitamin C, it is thought to support the endogenous catecholamine system. Low levels is seen in surgery cases. Can be used alone or in the HAT regimen, that is hydrocorticoid steroids, that is, and vitamin C, ascorbic acid, and thiamine. But there have been a lot of studies. The positive effect of vitamin C have not yet been proven in any of the trials as of now, and there are even trials which have even shown that it somehow causes harm to the patient. A steroid alone can be used, and it is used, but you can also use in combination, but most standard use it alone. Regarding the recent updates, vitamin C showed reduced vasopressor requirement in some studies, but as I have said, there is no consistency in the results. HAT regimen have not shown any mortality benefits. We need more researches on the therapies like methylene blue, HAT, and all those things. So to summarize, to treat this condition, you start with norepinephrine, that is your first line. Next, you go to vasopressin, which acts on the V1 receptor, and it adds on and it helps in restoring the tone. Next are the experimental things, like is methylene blue, angiotensin 2, and the HAT regimen. But one thing that is still considered a standard would be a use of steroids. Thank you for your patience.